Everything rises and falls on leadership. The ability to lead well is fueled by living your cause and purpose. This podcast will equip you with the tools to do just that. Live and lead with cause and purpose. And now, author of the book, The Anatomy of Leadership, and our host, Chris Como.
Hello and welcome. I'm excited today. This is my favorite time of the month when we do the top news stories of the month. Court Kastner, welcome.
Thanks so much. It's great to be back.
Yeah, I'm excited, Court. This is a show that we started envisioning last year instead of just going over the top news stories of the month, using our as framework and bring some amazing guests. So we've got some really amazing people with us today. This is the most people we've ever had on a podcast today. So let me tell our listeners who's with us. So we've got Bob Tavares, who's the VP and General Manager of Health Pivots. Welcome, Bob.
Thanks for having me.
Good. Great to have you. We have Robin Heffernan, who's a PhD and co-founder and CEO of Impassion. Welcome, Robin.
Thanks very much, Chris. Excited.
So good to have you. And we have Mindy Stewart-Coffey, who's the National Vice President of Palliative Care. Welcome, Mindy.
Yeah, nice to be here.
Yeah, so this is going to be, yeah, thank you. So this is going to be really fun. So to our listeners, Court and I usually kick off the month, just like we're kicking off this month. And in the past, we go over, Court would share the data from Hospice and Palliative Care Today, and I would share with you in my framework, hey, here's the articles from a C-suite perspective, director, leader level, that I hope you didn't miss this past month. And so we're going to keep sharing that data with you. But this year, and actually it was really Court's brainchild, we had the gift to Hospice and Palliative Care leaders. I think we kicked off December with it as kind of a Christmas gift, holiday gift to everyone. We brought Dr. Ira Byock, and he talked about his framework, but he also almost kind of feel like it was because he's such a patriarch, kind of the father, one of the mentors of many of us in Hospice and Palliative Care, wrote amazing books. Well, he did his framework and kind of feel like he was speaking to the whole field from his heart. It was just a beautiful show. And Court had this idea of, why don't we use his framework? Because Court uses that framework every month to organize his articles. Why don't we kind of theme shows that begin to kick off the month? And so today's that. And so you really could take any parts of his framework, the zero tolerance for waste, clinical and programmatic standards, making meaningful data readily available, driving competition-based quality, embracing our authentic brand. I think having this amazing panel that we have today, and we're really going to talk about the measures that matter. But I think as we get into the content, it's really going to touch on all of those. What do you think, Cord?
I think this is really amazing. I'm excited to kick off the year this way, and particularly with these three folks, we're just excited to operationalize, to make Dr. Byock's principles kind of come alive and apply them in the hospice and palliative care space. Just as a quick reminder for listeners, the top news stories from Chris's perspective and from our data collection side are still available online. So please click on those links and take advantage of those resources. And with that, Chris, you want to get us started?
Yeah, I do. In fact, what we do it this way. So Bob, Robin, Mindy, why don't you introduce yourself? Because you have such amazing backgrounds. I'd love for our listeners just to get to know you a little bit better before we jump into the questions.
I'll kick it off. I'm Bob Tavares. As you mentioned, VP and GM at Health Pivots, which is a market analytics company helping hospices, home health agencies, and others understand their place in the market and their referral patterns, their quality, and so forth. And I've been in healthcare analytics for about 25 years. As I'll tee up in a minute, the measures that matter really, this an effort that we've taken on is grounded in work I was doing 25 years ago to define hospital centers of excellence and hospital tiered networks. And we were all looking at each other saying, what measures should we use to define a hospital's quality? Employers and health plans wanted to guide their members to better quality, better value providers. How do you do that? And those lessons learned, I've carried forward. I find my career coming full circle, where I'm now helping the hospice market figure out how do we reward better quality and how do we do that in the context of value-based care. So I'm excited for this conversation, and I've got two of our expert panelists that were working with us on the Measures That Matter effort joining us. So I'm excited. Robin?
Thanks so much, Bob. Very excited to be on this podcast. Robin Heffernan, I'm the co-founder and CEO of Impassion. I'm a chemical engineer by training, so I love systems. And I'm mostly at this point a serial entrepreneur. I've done a number of businesses really focused on how do you help more vulnerable populations stay healthy at home and out of hospitals. So I've done some analytics work. I've done transportation benefit, meal benefit, home health benefit. Found my way to Impassion actually because in these other businesses, we would be serving patients. These patients would be quite sick and sort of clearly going into their last year of life. They would have great PCP care. They would have specialists, oncologists very often. And yet no one was talking to them about end of life. They were confused about what hospice or palliative care was, which meant they were largely not taking advantage of these great services. And so we thought, there's been a lot of focus around value-based primary care, around value-based kidney care, oncology care, and people have forgot that palliative and hospice care really is the next place that we need to focus. And so started Impassion, about the third year of the business. We've grown to be the largest player in this space. We have a national network for palliative hospice care. Have been working with Bob throughout on this task force because it's critical, particularly, and I think there's like 6,000 plus hospice players. We'll get into this, but the variability is extreme, right? And so how do you make sure that patients can get the best quality care wherever they are, and that we can reinforce the benefits of hospice?
Well said. Mindy?
Hey, I'm Mindy Stewart Coffey. Excited to be here with all of you today. I have a background in home and community-based care delivery. I actually started my career in senior living and then have kind of expanded over the last 20 years to lead long-term care, home health, hospice, palliative, and care management organizations. My background's in actually entrepreneurship and healthcare management, and I have a master's in public health. I actually made a little bit of a pivot in my career about 4 years ago. I joined Optum through Prospero Health and really wanted to deepen my work at the intersection of value-based care, post-acute care, and end-of-life care. They're all areas that I'm deeply passionate about. And I was excited to join Bob's task force to look at measures that matter, largely because of the work that we did as part of the VBID hospice demonstration. I think working in the hospice industry, I didn't necessarily realize, to Robin's point, the variability between organizations and, how difficult I think it is for consumers and, risk-bearing entities, payers, and others to really be able to identify quality hospices and palliative programs over maybe lower value or lower quality ones. So excited to have the discussion.
Excited to have you here. In fact, Mindy, you and I, because we've known each other for quite a while, you'd call me and share with me. You probably don't know this part, but you kind of were giving wind under my wings because of the work that we're doing in Tease, trying to create a high-performance hospice and palliative care network, and you seeing that variability, which we're going to get into. There was one more thing I probably should have said about what confluenced into today's show. Bob, my team at Tease had heard a presentation from you on Measures That Matter. They text me real time and said, you have to get Bob on a podcast to talk about measures that matter, and you need to do it sooner rather than later. And I think this was probably 3 weeks actually before you and I were together at the New York conference at Hip Caney's. So before we jump in, Bob, into the measures that matter, can you just set the table on the discussion, some of the demographics and kind of macro statistics that paint the picture?
Prior to joining Health Pivots as an employee, I was a customer. And I was in the data. I was helping build high needs ACOs, and I needed data to do so. And I fell in love with the Health Pivots platform and the data. And so here I find myself 3 years ago, January. So exactly 3 years ago, I started with Health Pivots. And I looked around at all of these quality measures, 40 plus measures. And I was surprised how many hospice CEOs had a poor understanding of what they were. They would often ask me, Bob, can you remind me what a burdensome transition is? And then a lot of the people that were in the know could barely articulate why they're important. So tell me more about early live discharge rates and late live discharge rates and per beneficiary spending. Clients would ask me, what's a good number for per beneficiary spending? Is lower better? Is lower better forever? Where $0 of spending is good value? Like, I don't understand what Medicare is trying to incentivize. So, and then the real kicker was the HIS measures, the HIS measures, where the best performers in the country get 100% score, and the worst performers in the country get a 99. So here we have these measures that everybody's frantically trying to track and improve, which are not differentiating at all, easy to gain, not valuable. So more measures is not better. Fewer measures that everybody agrees moves the needle on true definition of quality was missing. And having spent time in the hospital world building high-performing hospital networks, I knew we need to come to a consensus. We can't have, if you think about car ratings, if J.D. Power thinks that a Toyota Corolla is a top value car, but then, Edmunds or somebody else is saying this is a terrible car. We can't come to a consensus of how we define quality. It was important to realize that these quality measures are really good for extremes. We can identify a high-performing hospice, a center of excellence. And we can use the data to identify fraud or identify bad apples. But let's not kid ourselves or fool ourselves that the data is that good to differentiate that big middle core. So step one, if you're a VBID health plan, because think about this, 3 years ago, I realized that VBID is coming. They couldn't build networks in the early days of VBID, but I think it was scheduled for 2026 that health plans would be allowed to build a true network, exclude hospices. Who you want to exclude are those bad apples. But you also may want to reward centers of excellence. And let's not worry about the big network. There could be a lot of providers with good quality that are in the network. Let's carve out the bad apples. Let's reward the centers of excellence. And I just realized that there's not a health plan in the country that has that expertise in-house to interpret. They've never paid for hospice. They don't have hospice networks. How are they going to build networks? And if we leave them to their own devices, they're probably going to do it wrong. So can we pull a team of experts together to publish a report that explains and educates to accountable care organizations, which already have hospice in their budgets, and other risk-bearing entities, whether in or out of the CMS ACO models, as well as health plans, how to interpret this information, how to properly build a network. The task force had about 20 participants, and 2 of them are on the call today. We wanted to make sure we had representation from health plans, ACOs, some of the largest for-profit hospices, some of the largest not-for-profit, folks from NPHI and NHPCO, IRA was on the task force, as well as one of my favorites, Martha Twaddle, both past presidents of AHPM. So we pulled together a diverse group of folks, met monthly over the course of about 18 months to roll up our sleeves and hash these things out and settle on the measures that we felt were most important. We put out that first report this past summer, and I'm hoping maybe Court can join us in keeping that updated, particularly as HOPE measures come out. But that was the genesis of this was how do we provide guidance to ACOs, hospitals, at-risk provider groups, health plans on how to do this responsibly.
That's great. In fact, this is well said, Bob. I'm going to throw some stats in here, and then I'm going to hand it to you because you probably need to do maybe a little hospice 101, although our listeners are like, really? But I think it's going to help us get into really the meat of the measures that matter. But big picture, right? We look at the silver tsunami, although I've tried to not say silver tsunami as much anymore. John A. Hartford Foundation coached me to say, you can't do much about a tsunami. We know there's this huge aging population as the baby boomers are aging. Seniors in their final year of their lives represent 3 to 4% of the Medicare total lives, but it's the Pareto principle, 25% of our total Medicare spend is in that segment. And then we know hospice is a beautiful benefit. I'm super passionate about it. A lot of our listeners are. And we know it reduced costs by 25 to 40%. But as you heard from Robin and Mindy and Bob's intros, there's a lot of variability. Not all hospices are the same throughout the country. And unfortunately, the word hospice has become like the word Kleenex. People think from the consumer, they think all hospices are the same, but the data is showing much different. So what we're going to kind of get into is what they've learned through the measures that matter, what's currently measured and monitored. So let me segue now into a little bit more hospice 101 that sets the table. And I know a lot of our listeners are in hospice, but I think this will level set. Of course, we know there are 4 levels of care: the routine home care, the general inpatient care, continuous care, and then respite care. But when we look nationally from a payer perspective, anywhere between 90 and 95% of most of hospices, Medicare is that primary payer. Then you might have another 2 or 3% that is Medicaid, and then your remaining is either indigent, unfunded, or private pay. So when you look throughout the country, the vast majority of hospice care is paid for by Medicare. And then Medicare has a few things that it actually mandates, like HOPE is new, although there are some penalties that you could pay and then not report HOPE. I think this one is 4% on HOPE. And then CAP scores, but then there are a lot of hospices that opt to not do CAPs, or they don't because they're too small. And Cord, is that ends up like is it 50% of hospices in America, or is it less than that report CAP scores?
Oh, you're right on target, Chris. About 98 to 100% of hospices are reporting hospice items set in claims-based measure questions. And then with CAPs, it's about half. And then with the star ratings, only about a third. I think the most recent number is about 29% of hospices have reportable star scores. So while it's great that Medicare has these quality measures available and that there's some utility and usefulness in what is available, when hospices are missing this information, it really leaves the payers as well as the patients in a bind for not really being able to differentiate between quality providers.
I recently had a conversation with a good friend, Julie Ehlert Kennedy. She's the Chief Experience Officer at ECU Health. And she was just sharing with me quite a bit. In fact, we might do a podcast this year about how a lot of people in healthcare are choosing based upon Google ratings. And think about, like, we're now in the Amazon world, right? How many of us, we go to purchase something in Amazon, and you're like, that one's got no reviews. I'm not going to purchase that one. But this one has reviews, and they got this many 5 stars. I mean, it's becoming just part of our ethos, and yet you've got just such a mixed bag, which maybe, Robin, that's a good segue. Just, you alluded to this in the intro, just the variability that you see from your perspective.
Yeah, this is a really important topic. I think sort of I would echo the framing in the beginning first of when hospice is done right, it is better for the patient, it is better for the caregiver. You can save anywhere from 25 to 40% on total costs, right? And so that's why we care about hospice being done well. And the largest issue that we face is how do you get consistently great hospice? So Impassion runs a network of hospice and palliative care. We have tens of thousands of providers across 45 states. Some providers are large nationals, whether they're for-profit or not-for-profit. Some are regional. Some are, very small mom and pops. None of those dimensions is indicative of whether they will perform well or not. And so we got really excited working with Bob and Health Pivots when we launched the business to look at some of these CAP scores and outcome metrics and say, okay, can we be smart at least about, let's not pick someone to be in the network or if they're in the bottom 50% of a county coverage, just at a base level. So you do that. And then what you still see is, the discrepancy between the top 50% in that county is still wildly extreme. You'll have some groups who are really good, and really good sort of means they get in there early, they're talking to the family members, hospice isn't this surprise at the end, they're using a full care set. I think we'll talk in a lot more detail about the specific measures that matter, but Some groups do that well, and they do it well in a certain county, and then you can have the very same parent company in a separate state or a separate county, and they're miserable at it, right? Or you might have someone who's really good, and then there's a lot of staffing challenges in this space, and so they lose key staff, and now they are not good anymore. And so I think this work that we've been doing to say, can we figure out some metrics that are not onerous for the people who need to deliver care, but that are really meaningful and give us good insight into who's going to be high performing, so that we can build these high performing networks and we can reward these great providers and we can weed out the really bad, fraudulent providers, is going to be critical for growing this industry.
That's good. Robin, I didn't tell I was going to ask you this, but I was so fascinated when we were in the green room about your background in chemical engineering. Is there any lessons there? Like, if we look back in the history of chemical engineering, was it standardization and process and measure, or either or that kind of helped? I mean, because that field is incredibly advanced now, right? Is there any lessons to be learned there is kind of my question.
Yeah, this is a good question. I think, the main thing for any engineer, right, is they look at the system. And this sort of gets into, how do you describe value in this space? And we really think about it as, okay, if this is the last year of life for this patient and their family, how is it as good as possible? How are they having as many good days as possible? And can we do that in as large a scale as possible, right? So if you want to scale it, well, it needs to be financially sustainable. It needs to be something, that's not a totally manual process with a bunch of glue and duct tape. But first and foremost, it needs to have great experiences. That's what we're trying to give patients and their families. That's why everybody goes into this field. And so I think as engineers, you are trained in the beginning to look at the whole system, figure out where are the biggest levers in that system that you need to optimize, and then go do the work to try to make each one of those levers as efficient as possible.
That feels like a little mini masterclass just right there at the very end. That's awesome. Well, Mindy, let me ask you, what challenges that you've seen in building and operating a hospice network? Because you've done it at a pretty large scale.
Yeah. I would say one primary one is really just engagement and collaboration from hospices. I think most hospice organizations that we work with have not had a lot of experience working with like a risk-bearing entity or a value-based program. And I think that sort of ongoing collaboration is something that many of them weren't used to. I think that they were used to receiving a referral, taking over the care of that patient, and then that's it. Then you're collaborating only within your interdisciplinary team and maybe some other care team members externally as needed. But in, I would say in like large sort of risk arrangements or population health strategies, you have an interest as, the person that's sort of managing the risk on the population or the patient to stay engaged. And so I think that kind of ongoing engagement and collaboration was something that was new for a lot of organizations. A lot of people were like skeptical. And I would say often we would find, particularly smaller community-based hospice programs that were amazing. They have amazing outcomes. But, their attitudes were sometimes like, leave us alone. We're not interested in doing, that kind of work. And, the other thing, I'll just echo what Robin said as far as operating a hospice network long term. It's not a set it and forget it exercise. You can't just form the network and then the network sort of stays in place forever and for always. Things change, quality improves, it declines, processes fall apart within organizations. You could have a really good process for, referral, intake, collaboration, follow up. But it was riding on maybe like a really amazing intake coordinator or a really amazing clinical director. And if those people change, then you start to see, changes in the agency and the organization. So you could have top quality hospices that then start to fall to kind of the bottom of the pack. So you always have to be monitoring for what's going well, what's not going well, and who's maintaining high quality versus those that are kind of, peaking and rising.
That's so well said, Mindy. I'm always a student of Deming, who was kind of really the father of quality. And one of his adages that we teach is RPTH. You might remember Mindy us talking about that many years ago, which stands for Resource Processes Training Human Factor. It's hard to boil Deming down to like one principle, but that's the one that stuck in my brain. And you look throughout, I was lamenting recently about this work that we do within Teleas Collaborative Network. I have a lot of gray hair now because working within this network, you're right, you can't just kind of set it and forget it. But we do so much work around do we have the resources? Do we have the processes in place? Do we have the training to make sure then the resources are properly deployed where we're reducing variability? And then the H is the last thing, human factor. And Deming would often say, we go, oh, bad person, you didn't do the right thing, but you didn't say, did you have the resources? Did you have the processes? Did you have the training? And did you even do the training in the right way? Where is it really accessible? Then you get to the performance, the human factor. And quite often, I think in hospice for many years, we've just depended upon the human factor. Just hire great people and they'll do great work. And this is why I think one of my theories of why we've seen this variability. So it feels like in this first segment, we've really just set the table.
We will be continuing this conversation, measures that matter, how better metrics can transform end-of-life care. This Friday, February 6th. Be sure and share this episode and subscribe to our channel.